Dr. Cassell is the Senior Technical Advisor for USAID and PEPFAR supported linkages program at FHI 360 covering the Asia region. He formerly served as the Regional HIV and TB Advisor for USAID and has served as a HIV Technical Advisor to the US government for more than a decade in posts in Thailand, Cambodia, Vietnam, Botswana, and Washington. He has a doctorate in health behavior and health education from UNC, a master's degree in journalism from Stanford University, and a master's degree in environmental management from Duke.
One of the things that I just want to start with is every time I'm engaged increasingly, thanks to some of the leadership of our esteemed panelists, in a dialogue around the need for key population-led services, the dialogue usually starts something along the lines of, wow, I'd really love to pursue those are so important, but. Okay, so when you hear the but, I'm a behavioral scientist, when you hear the but, that's a sign of ambivalence, and ambivalence is a barrier to action. So really this panel is about trying to break the chains of ambivalence, just like the debate was last night. To try to move forward and take action together. So the first but is usually about funding. So I just want to try to quickly, with one slide, if possible, get the funding issue and the investment case off of the table. So in the Lancet Global Health, looking at some of the India experience, India is still, I believe, the only country globally that has made large, substantial domestic investment in key population-led services. These were services that we're talking about here that actually preceded some of the solutions. We know how to end AIDS solutions that Dr. Nitya has been talking about, preceded the ending AIDS with antiretroviral solutions. Very simple sort of organizing around key population-led community services and outreach, and they were indeed very cost-saving in the India context. Smart investments that saved more than $20 million in terms of averted treatment costs in the long term. So when we talk about key population-led services, I really want to try to put things in the global context and indeed in the Asia Pacific context in terms of closing the gaps towards 95, 95, 95. And if it's not about money, as we've seen declining treatment costs and we've seen the ability to mobilize other resources, and if it's not about how do we end AIDS, because Dr. Nitya, and I trust her, says that we have the solutions in hand, so we should be able to do this, then what are these persistent gaps that we're still seeing here about? And I want to ask you just to work with me a little bit and think about these maybe a little bit sideways. Think about these as potentially a human-centered design challenge. Okay, so one way of looking at these bars is to say the people in the blue, because it's not numbers, it's people, are people that to a greater or lesser extent we are meeting the preferences and needs of to the extent that we're actually engaging them in some way. But the people in the red are people that we're not yet meeting the preferences and needs of. And we need to be thinking about how to tailor services to better address those gaps. So no one-size-fits-all solutions, and recognizing that just as standardization and scale are key to a public health approach, so is differentiation. So when we think about it that way, if you're still with me, thinking about this as a human-centered design issue, then one way of thinking about the need to achieve 95, 95, 95 and the road to achieving epidemic control is to think of this challenge as being a challenge of taking the tools that allow us to envision an end to AIDS, the tools that many of you researchers and doctors have actually put in our hands, and taking those and putting them in the hands of the key populations in which they can have the greatest benefit. So that's really what key population-led services is about. It's about recognizing that these tools, these solutions need to be within reach, if not directly in the control of the people that they will benefit most. And so when we think about that in terms of the HIV cascade, then we have an opportunity to think creatively about how we can actually put key populations in leadership positions, in better leadership positions across the cascade, from reach and engagement and outreach, but also many of the solutions that Dr. Nitya referred to on day one in terms of things like lay testing, HIV self-testing, antiretroviral dispensing, both PrEP and treatment in community settings and led by key populations, and thinking about differentiated models that tailor to people's preferences and needs. So with that in mind, there has been a lot of discussion about differentiated service delivery. So what you're seeing here is actually an adaptation of the original differentiated service delivery sort of diagram that was depicted in the paper that's referenced. But again, this notion of instead of organizing people around services, which I will admit I do a lot as I think about protocols and workflows and processes, trying to turn this all on its head and design services around people. So thinking about the people that we are trying to benefit, what their most important needs and priorities are, and then organizing our services around those to the extent that that's possible. Now, when we talk about differentiation, again, a red flag goes up and says, well, we can't possibly tailor to everybody's needs because that's not necessarily cost efficient. But there are ways to think about efficiencies around differentiation, because if we actually are able to prioritize according to people's preferences and needs, we can recognize that there are some people who may need less support, and that frees us up to provide more time and support for people who have fewer needs. So again, thinking about how we can actually differentiate. So, with that notion in mind and thinking about the person first, I just want to walk through some of the different approaches that we could consider in terms of key population-led services and how those sort of fit this model of differentiation. So here, very complicated, apologize for the slide, but you can see across the top of this, there's basically part of that differentiated circle that I was talking about. And this part of the circle looks at people's preferences in terms of how they would like to be reached. Would they like to be reached through face-to-face interaction? Would they like to be reached in the virtual space through virtual interaction? And under the linkages program, which is a program that I work with FHI 360, we can think about at least 3, if not more, different kinds of engagement in the virtual space, which includes basically reaching people through targeted online ads here, through social influencers, the Insta-famous and popular celebrities and individuals who have followings on social media, and then through outreach in the virtual space, just as you do physical outreach. And through each of those different channels, you can look at ways that you can track people and link them to what I have depicted here, which is an online to offline linkage platform. So people can click on a targeted ad, be linked to a site where they can actually choose, according to their preferences, to get an appointment at different settings. And indeed, we're even looking at options to be able to ship HIV self-test kits to people, and looking at differentiated options in terms of engagement, to cast a broader net and to offer broader access to services according to people's preferences and choices. So with that in mind, just some very early results of what you see. When you offer differentiated options, you actually also see, unsurprisingly, differentiated outcomes. So in this case, we see that for testing in the orange bars, we tend to see a little bit higher testing uptake, successful testing uptake from referrals from social influencers. But what we find too is that of the people who actually get an HIV test, we see higher rates of seropositivity, higher rates of case finding among people who actually self-guide by clicking through a targeted ad. So these are people who otherwise would not have been accessed through face-to-face or through social media communications, but actually did see a targeted ad, maybe were considering that they were at risk for HIV, didn't feel comfortable talking to somebody, clicked through, made an appointment, and had higher rates of seropositivity. So again, thinking about differentiation as a way to close these gaps and cast a broader net. Okay. So again, another sort of approach is thinking about how can we actually put testing, put diagnostics more and more in the hands of key populations. So in Thailand, and I know Vietnam's been doing work with self-testing, and Laos, other countries in the region. In Thailand, we were able to get support from the Thai government to work on a study together looking at options for expanding HIV self-testing through community organizations largely focused on men who have sex with men and transgender women. The enrollment options were interesting. People could actually be enrolled through face-to-face contact in the community through community workers, but also there was recruitment for the study online through social media. And what we see is that both for men who have sex with men on the top and for transgender women on the bottom, most people were actually enrolled face-to-face, but we see differentiated preferences when we actually look at people who are enrolled face-to-face versus on social media in terms of whether they would prefer to actually have someone assist them with the oral fluid kit and actually help guide them through the process, or whether or not they'd actually like to have it sent to them and do it themselves. So people who are actually reached on social media, who are men who have sex with men, actually preferred to do self-testing and not talk to somebody as part of that process. And then as part of this protocol, there's ongoing support online and actually through phone and through face-to-face as people would like it to navigate to treatment. Okay, moving on quickly because I want to respect the time of my other colleagues and I want to hear actually what they have to say. But I think we can really take this as far as we possibly can imagine. So when we really think about engagement and leadership of key populations, an emerging priority as we have globally more than half of all people living with HIV on treatment already, far more than half already diagnosed, is recognizing that globally we still have a 15, 16 million person treatment gap. And so is it possible, given that we know about how HIV is transmitted from person to person, that the more than half of PLHIV that we're already engaging with may have some connections with that other half that we have not yet engaged? And can we engage their leadership in a constructive, supportive way to close this gap, right? So one way of thinking about this is the global pool is 7.6 billion people. Do we test 7.6 billion people to try to find 15 million? Or do we try to actually engage people who are living with HIV in a supportive, constructive way to see if they might be able to support referrals of people they know who may be at high risk? So again, trying to draw on a differentiated approach. To do this, I think the most important thing is to put the person in front of us first. So what we've been talking about to pursue what people are referring to as index testing, engagement of people living with HIV to support referrals, is making sure that first and foremost we are providing high quality services to the person living with HIV, supporting their treatment needs, because only if we do that can we actually think that it's likely that they would feel that the services are sufficient quality that they would recommend them to other people. So really valuing and supporting that relationship, and then recognizing that we're providing something of value that's appreciated, then asking, all we ask in return is for you to refer people that you think might also benefit from these services. And then there, providing a differentiated set of options. So we have WHO guidance on partner notification, but we're trying to expand beyond that as well and not require elicitation of contacts, to allow people who are living with HIV to self-guide in terms of how they make referrals. And to do that, we can use basically peer-driven recruitment strategies that are focused on people living with HIV, that are supportive, give them options. And when we've tried that in Chiang Mai and Thailand, we've seen a 4-fold increase in case finding rates engaging people who are positive in these referral structures. Okay, and I have just 3 more slides left, 2 minutes. I don't want to drill down in details on this, but again, credit to the Thai Red Cross and to the partners in Thailand for expanding PrEP. We're still not globally where we'd like to be, but this trend line is looking better. But I think the thing that we'd all like to focus on here is that more than half of all this PrEP take is community-led and is actually on a fee-for-service basis. So again, where we see increases in PrEP in San Francisco and other places, it's been community-led and driven demand. And we really need to focus on trying to promote that and appreciate that to scale things up. It's not about us just expanding services. It's about engaging community members in their leadership. And then same-day ART, this is a different way of looking at some of the data that Dr. Nitya was sharing earlier, but I just want to point out Here in this fourth quarter of FY17, we see very, very substantial increases in ART uptake associated with same-day treatment initiation. Part of this is a data issue, is actually being able to document that people have successfully been initiated as opposed to referring them somewhere else and then worrying about how to follow up. But this does seem to be aligned to people's preferences. It seems to be associated with better outcomes, and it gives us opportunities to provide better follow-up. So, last, my summary points. I really firmly believe that our success in ending AIDS and this vision is really going to be associated with our ability to take these fast-track innovations and solutions, the how to end AIDS models that Dr. Nitya has been talking about, and putting them in the hands of the populations in which they'll have the greatest benefit. Doing that entails differentiation. It also entails a public health approach that involves scale up, that involves standardization, but it involves differentiation and involves community leadership based on people's preferences and needs, and that means broader engagement. And no one understands these preferences and needs better than key populations and people living with HIV themselves. And the services that many of us are providing are services that they indeed can provide, and I would submit, just to stir the pot, may be able to provide better. But we would all benefit from those kinds of partnerships because we would be able to task share and task shift. Thank you. I'm 17 seconds over time.
So maybe I can kick things off then, Michael, and I have a question. I think linkages is probably the one of the, if not the kind of most well-resourced and known key population-led service intervention or project in the region. You mentioned in your presentation how you use data to adjust program quality and service delivery. And I was just wondering, on a kind of more macro level, what are the plans that you have or the actions that you do in terms of advocating at perhaps a policy level for key population-led services in the region?
Yeah, so I think as a global project, we aim to serve key populations. Many of the people who work on the projects are key populations and people living with HIVs, but we do not speak for those communities. We have a linkages advisory board, and they guide us, and they, I'll be on a call over the weekend, actually, with members of the advisory board expressing concerns about different things and trying to move the agenda forward. And that's the kind of engagement that is really quite important, that kinds of leadership. What we try to do is be able to build and share experiences across countries that may help to link key populations because of the privileged status that we have as a global platform. And so that's nice. We have an opportunity to kind of connect the dots across countries that perhaps we have not had previously. But again, it's not about the project, it's about serving key populations. And then what we look at is these kinds of agendas around, can we expand virtual engagement? Can we look at lessons learned from Thailand and PrEP and bring those to other countries? How do we actually build that sort of catalytic response by sharing lessons learned?
Thank you, Michael, very much for wonderfully set the stage of the term KPLHS. And I understand that for audiences in this room, in each of the country that you are coming from, you probably have many various levels of understanding or level of familiarization with working with key populations. I just would like this session to be used for you to familiarize yourself with the concept and also to think a bit more seriously, get over that concerns or that ambivalent about working with KP communities, because some of you may think that you are already working with KP communities because you have CBOs referring people to you. That's a very good start, but I think that we can do much more advanced than doing so. So I just would like you to really think along the way while you are listening to our panelists here on where you are in this development. So thank you, Michael, for setting the stage for us. And Michael talked about the concepts of KPLHS and showed some data as a whole for what KPLHS can bring to you in terms of achieving those 90-90-90 targets and looking at the cascade in each settings. We'll be hearing from the other two presenters following Michael how we really translate that concept into implementation, which I think is like the key theme for APACC conference, how we translate science into clinical practice, how we translate concept into the actual implementation.